Good morning all. We would like to discuss about our study on demography, clinical picture and etiology of occurred isolated third cranial nerve palsy. Third cranial nerve palsy is an important neuro-ophthalmic disorder with diverse etiologies ranging from benign microvascular ischemia to life-threatening aneurysmal compression. The clinical presentation varies in pupil involvement, ptosis, ocular motility deficits, influencing the diagnostic and imaging decisions. The population-specific data on etiology and demographic pattern remain limited, so our aim was to retrospectively analyze all the cases of occurred isolated third cranial nerve palsy presented to our institute, which is a tertiary eye care center, during the last 15 years, and to describe the demographic characteristics, clinical picture, and the etiologies. For that, we retrospectively analyzed all the electronic medical records of all patients diagnosed with the same between January 2010 and May 2025. For that, we collected the data on demographic details including age, sex, laterality, clinical presentation, ptosis, diplopia, motility, pupil involvement, and medical history of comorbidities, trauma, surgery, and the investigations done including neuroimaging, vascular studies, and laboratory investigations. Based on this data, we classified the patients into presumed ischemic, compressive, including aneurysms and masses, traumatic, inflammatory, and others, and also checked the treatment offered and recovery status at the 6 months. A total of 63 patients were included. The mean age was 65.8 with a standard deviation of 14.5. The highest incidence was seen in the age group of 61 to 70 years. 39 patients were males with a male to female ratio of 1.6. Right eye involvement was seen in 25 cases and left eye in 26 cases. Bilateral involvement in 2 cases. Among 63 patients, 74 patients had various medical risk factors. Nearly 2/3 of patients had diabetes mellitus. Double vision was the most common presenting complaint, which was complained by 2/3 of the patients, followed by drooping of eyelid. The extraocular motility limitations was universal, and the ptosis was present in 82% of patients, pupillary involvement in 27 cases. Patients with normal MRI brain and orbits and laboratory investigations and having microvascular risk factors were included in presumed ischemic group. 8 patients could not be included because of the lack of follow-up, and so total 55 patients were classified into presumed ischemic, which contained 55%, compressive, aneurysm and tumor 6.3% each, traumatic 9.5%, inflammatory or infective 4.8%, and others 4.8%. This is the pituitary contrast enhanced MRI of a patient with pituitary macroadenoma, and this is the aneurysm of right eye ICA. Among the presumed ischemic group, 33 patients were diabetics. Out of that, more than 2/3 had diabetes for more than 10 years. Within the presumed ischemic group, 10 patients had NPDR and 2 patients had PDR. The pupil involvement was more common in the compressive lesions compared to ischemic causes. Pupil was involved in all traumatic cases and 2/3 of the inflammatory causes. Only 14 patients of ischemic cases came for follow-up after 6 months. Out of that, 57.14% showed complete recovery. In compressive lesions, 2 patients underwent surgical management and recovery documented in 1 case. Age pattern and the male predominance in our study was comparable with the previous studies, and the diplopia and ptosis were the most common presenting problem, with the pupillary involvement seen in more than 25% of patients. In our study, the most common cause was microvascular, followed by trauma, then aneurysm, tumor, then inflammatory or infective, and others. This order was similar to the studies conducted by Fancy et al. And Noorulainen et al. Inflammatory and infective etiologies were less frequent but clinically relevant. The ischemic palsy was strongly associated with systemic vascular comorbidities, particularly diabetes. Nearly 2/3 of diabetic patients in this group had diabetes for more than 10 years, and 1/3 exhibited diabetic retinopathy. The recovery varied markedly by etiology, and out of followed-up patients, 57.1% showed complete recovery. Recovery in compressive lesions was limited. Strength of our study include relatively large cohort for a single center eye care institute and availability of systemic risk factor data including duration of diabetes and DR status, and the limitations are retrospective design, incomplete etiological workup, and poor follow-up. So we concluded that ischemic or microvascular disease was the most common etiology, which was strongly linked with long-standing diabetes and other vascular risk factors. The absence of pupillary involvement in 50% of compressive cases highlights the need for neuroimaging in all suspected third nerve palsies. Relatively favorable recovery was noted in ischemic group. The compressive and traumatic palsies demonstrated limited improvement unless treated. So we recommend ensure optimal control of systemic risk factors, especially in elderly patients. Consider early neuroimaging in all third nerve palsy cases to avoid missing vision or life-threatening conditions. Urgently recognize and manage compressive and traumatic third nerve palsies to prevent irreversible deficits. These are our key references. Thank you.
You've done two cases, you have something, surgery was done. What surgery was done those two patients? Those two patients.
Case of endovascular coiling. One case of aneurysm, endovascular coiling was done. That was recovered.
Aneurysm of what? Which artery?
Right ICA aneurysm.
What?
Right ICA aneurysm. Internal carotid artery aneurysm.
Right side?
Yes, sir, right.
Internal carotid. Internal carotid artery.
Yes, sir.
Location? Where?
Cavernous segment.
Cavernous segment.
Yes.
Then isolated third nerve palsy.
Yes, sir.
Isolated third nerve palsy, can you get?
The clinical presentation was isolated third nerve palsy.
Then other nerves were involved. Okay, isolated third nerve palsy, normal teaching, of course, you can tell nothing wrong. Okay, but you must tell usually posterior communicating artery we expect. Because it's side by side, it's passing along with the third nerve. Whereas internal carotid artery aneurysms and all, you can expect mainly involvement of cavernous sinus area. You can have other involvement of other nerves also. Very rarely we have got one thing called above the clinoid process. That's called supraclinic aneurysms may produce. Very rare possibly may produce isolated third nerve palsy. Okay.
Okay, sir.
But you have already told because everyone knows that. What's the difference between surgical problem of third nerve and medical problem of third nerve? Suppose a diabetes produces third nerve problem. Surgery aneurysm producing third nerve. What is the prognostic finding? What will happen? We follow the person.
The medical is recovery is better, and then surgical if intervention is done.
Only one question, no. I don't take it seriously, but the problem is what here. We want to relax and learn something else here also. Can you tell me which is called oculomotor nucleus? Which is classically called as oculomotor nucleus. It's oculomotor now, no?
Yes.
You tell me which is called oculomotor nucleus.
Edinger was true.
Huh?
Edinger was true.
Sure. Are you sure or not?
Yes.
You should only guess.
Yes.
Very good. Okay.
You see, ischemic cause is favorable. The dictum is, if there is a third nerve palsy, because of ischemic cause, it has to recover. Okay, the period is between 1 month to 6 months. If it is not recovering, then the reason is something else. What was the inflammatory cause of third nerve? What was put in your study?
Tolosahan syndrome was the
Tolosahan. But how do you manage that? Where was a lesion, inflammatory lesion? It will be better if you show images, neuroimages based, especially so that you'll know what inflammatory cause you'll have come across. What are the other compressive causes of third nerve apart from pituitary tumor and aneurysm what you came across?
hemorrhages.
Does all compressive third nerve, after the reason is addressed, does the recovery is complete?
No, ma'am.
Huh?
No, ma'am.
Why? Start thinking that way. You will understand the reason, everything much in a better way.
Thank you.
Prospective study is that you already have so much of details, you want to go and glean details out of it or the salient features out of it. I don't know whether you have done anything regarding demography, clinical picture, and etiology in optic nerve, in the oculomotor nerve palsies, as you demonstrated. You just bring up one or two scattered findings here and there. Nothing becomes cumulative into some knowledge point, some action point. That is the issue. That is why you yourself said that most of the patients didn't turn for follow-up. You don't have good follow-up of all your patient base. So probably you weren't able to pick up many of the findings which should have been picked up. For example, if you have given an etiology spread nicely, that these are the reasons by which we had, or if you have said like clinical outcomes, this many patients recovered, this many patients had pupillary involvement, this many patients has aberrant innervation, like that, I don't see any tables here. There is no tables to demonstrate the aim of your study, which is to bring out demography, clinical picture, and etiology of acquired third nephrosis. You this many RTA, this many tumors, this many. So that kind of correlation is very important in retrospective studies. We do retrospective studies only because we have data already available. We want to take salient points out of that data. Okay. So whenever you are deciding a retrospective study, then you'll have to be more exhaustive and more thorough. If in a prospective study, you might have handicaps. In a retrospective study, most of the times you have good data, and the data analysis should show that in the study. Okay.
Okay, sir.
Thank you.
Thank you.
Your case mostly what? Ischemic type, you told, no? Ischemic
Yes.
nature. Did you follow them up after some time also? You told you are not followed properly. Can you tell me what type of aberrant regeneration these fellows of ischemic type can develop in future? Aberrant regenerations. Suppose diabetic patient is there. He's having a third nerve palsy. In future, what are the various types of aberrant regeneration that fellow can develop diabetic patients? Hello?
Yes.
You don't know? Hey, you know aberrant regeneration or not?
Yes, sir.
You tell me something. You know one thing, your answer should be, sir, ischemic conditions like diabetes, future they will not develop aberrant regenerations. Only traumatic patients, aneurysm patients, they all will develop aberrant regeneration usually. Whereas ischemic problems, normally we don't expect. Understand now? That's why we ask these questions. Okay.
Thank you, sir.